The midline of the lumbar spine over the level or levels of interest is marked out either by palpating the spinous processes and apex of the iliac crest, L4 to L5, or by use of intraoperative AP and lateral fluoroscopy. In a unilateral approach, a paramedian incision is made approximately 2 to 2.5 centimeters off the midline over the level of interest. Any commercially available tubular dilating type system may be used to split the paraspinal musculature and dock a tubular or expandable retractor onto the laminofacet junction under fluoroscopic guidance. This initial exposure then reveals the ipsilateral lamina and base of the spinous process as well as the medial facet complex. Residual soft tissue at the base of the tube is removed using monopolar cautery and pituitary rongeurs. It is important that this dissection begins laterally and superiorly to avoid inadvertent penetration into the interlaminar space with the cautery. A curette or other dissector can then be used to identify the inferior edge of the rostral lamina and superior edge of the caudal lamina, as well as clean out the interlaminar space. A hemilaminectomy and medial facetectomy are performed using a high-speed drill and kerosene rongeurs, once again taking care to avoid stripping the facet capsule or removing excessive amounts of the facet. The ligamentum flavum is left in place at this point, and the tube is then angled steeply toward the contralateral side. The undersurface of the spinous process is drilled away. The ligamentum flavum is dissected off the inner surface of the contralateral lamina and facet with curettes and blunt dissectors, and these contralateral bony structures are drilled from within the spinal canal, using the ligament and suction as guards between the drill and dura. After accessing the contralateral lateral recess in this manner, the ligament is then dissected away from the bone edges and dura and resected bilaterally. The contralateral lateral recess is decompressed with kerosene rongeurs as described for the open technique. The tube is then angled back to the ipsilateral side for final ligament removal and lateral recess decompression.